Today we're going to discuss enuresis. As a quick anatomy review, the bladder is made up of a muscular wall. When sympathetic innervation is going to this wall, it relaxes and the bladder passively fills from urine from the ureters. When one is ready to void, parasympathetic intervention then allows this musculature to contract while simultaneously relaxing both the internal and external urethral sphincters, allowing the person to void. Enuresis is when a person is unable to void as planned. It can be broken into two groups, either daytime or nocturnal. Daytime enuresis can then be further broken down into two groups. A storage issue, meaning that the bladder is unable to hold the urine, or an emptying issue, in which it fails to completely empty. Storage issues can then be broken into whether the patient has normal neurological exam or an abnormal neurological exam. If it's a normal exam, the bladder is unable to fill and store at low pressures, while if they have an abnormal neurological condition, this causes high pressure, causing the bladder to leak and be either hyperactive or have an abnormal sphincter. Examples of these issues include urge incontinence, overflow incontinence, diurnal enuresis, and frequency. When looking at emptying issues, these can be broken into neurological issues, in which the bladder does not cause the musculature to contract appropriately, anatomical issues, in which the urine is unable to leave the bladder, muscular issues, in which the musculature is insufficient to cause emptying of the bladder, and functional, which is the most common. Some conditions that fall into this category include lazy bladder, in which a person voids less than 3 to 4 times a day, causing atrophy of their bladder muscles; DSD, in which there is an inappropriate increase in the external urethral sphincter tone, causing it to be difficult to void. Over time, this can cause a buildup of urine and cause Hinman syndrome. In contrast, there are two categories of nocturnal enuresis, which by definition only occurs at night, or is also known as bedwetting. Primary enuresis means that the patient has never been dry, and they must have an accident every night for 6 months over the age of 5 years. Secondary enuresis is a new onset of having bedwetting after the patient was previously dry for 6 months. Usually this is related to stressful events in the life and will self-resolve. It should be evaluated the same as primary nocturnal enuresis. The causes of nocturnal enuresis include bladder dysfunction. In this case, the patient either has a small capacity bladder or an unstable bladder, which can cause them to void more often. This is often also accompanied by daytime enuresis as well. The second mechanism is increased nocturnal urine. There have been multiple studies that have shown that patients who tend to have bedwetting produce more urine at night. This is thought to be related to a decrease in ADH in these patients. The third mechanism is related to family history. If one parent had a history of bedwetting, their child will have a 44% chance of also having bedwetting. If both parents were affected, this increases to a 77% chance. Also, interestingly, the parental age of resolution tends to predict when the child will also quit having bedwetting episodes. The fourth is other health conditions. One of the most common that has been associated is obstructive sleep apnea. This causes an increase in your atrial natriuretic peptide, which then inhibits your renin-angiotensin-aldosterone pathway, increasing diuresis at night or causing more urination. Lastly is psychiatric. Children with ADHD have an increased risk of 30% of having bedwetting episodes. This is thought to be due to a neurochemical event. Additionally, one of the most common theories related to bedwetting is that it represents a maturational delay, as many kids who have bedwetting also have fine and gross motor clumsiness and speech disturbances. This, along with children with ADHD, are also more likely to have daytime enuresis as well. Overall, nocturnal enuresis resolves at about a 15% rate per year. When evaluating enuresis, there are many similarities between the evaluation of both daytime and nocturnal enuresis. First and foremost, your history is key. You want to take a good voiding history, that is, how often the child urinates, timing of urinations, timing of accidents, and whether or not these are intermittent or if they have constant wetness. Additionally, you want a good history as far as their fluid intake during the day and the pattern of this intake. You also want to look for other urinary symptoms such as polyuria, polydipsia, urgency, frequency, dysuria, an abnormal urinary stream, or history of UTIs. You want a good bowel history. This is knowing the number of stools, consistency of stools per day, as well as if they have any abdominal pain or stooling accidents. Next, past medical history is important. This includes things such as history of urinary tract infections, bowel complaints, and sleep disorders. The third component you want to delve into is their developmental history, as again, many kids with bedwetting episodes can have a developmental delay. Fourth is family history, especially a family history of enuresis in the parents themselves. Fifth is a social history. This is looking at recent stressors in the family as well as the parental response to these accidents and what has been done in the home so far to try to remediate them. Next, you'll move on to your physical exam. While you want to do a complete physical exam, there are 3 areas you should pay particular attention to. This includes the genitourinary area. You want to do a good external exam to ensure that the meatus is open, there are no vaginal adhesions or penile adhesions that could block the flow, and that all external anatomy appears appropriate. Additionally, you need to do a thorough neurological exam, focusing especially on the lower extremities. This includes looking at the tone, strength, and reflexes of the lower extremities, as well as examining the spine for evidence of hair tufts, sacral dimples, or other lesions overlying the spine that could indicate an anomaly. Third, you want to focus on your abdominal exam, palpating for any masses, whether it be an overfilled bladder or a stool ball, also paying attention to any areas of pain. Once the physical exam is completed, all children with enuresis should obtain a screening UA. This is looking for several things. 1, the specific gravity to let you know the concentration of the urine. 2, looking for protein or glucose in the urine that could point to other etiologies increasing their urination. And 3, looking for signs and symptoms of infection. If there are any signs of infection, such as white blood cells, leukocytosis, or nitrites, this urine should be sent for culture. In most patients, this will be normal and no further evaluation is required. However, if patients have recurrent infections or daytime enuresis, they should proceed with a bladder ultrasound, also sometimes including the renal. For daytime enuresis specifically, you should evaluate for the post-void residual, or the amount of urine that is left in the bladder after the patient has voided, as this will give an indication as to whether or not this is an emptying issue. Other tests that can examine the ability of a patient to void include the uroflow test, which measures both the amount of urine and the speed of flow and can detect problems such as urge incontinence, sphincter dysfunction, and obstruction. If the patient has a history of having constant wetness, you should evaluate for an ectopic ureter. This can be done through several modalities, including MR urography, a CT scan, or pylography. There are several treatment options when it comes to treating enuresis. For both daytime and nocturnal enuresis, behavioral changes will be a large component. This includes during the day, voiding every 2 hours, and also double voiding. Additionally, it includes encouraging the child to sit on the toilet for 30 minutes after large meals and continuing a good bowel regimen program. For nocturnal enuresis, a more specific component of this includes bed alarms. Bed alarms are alarms that go on the bed and alarm once the patient has wet themselves, waking the child up, or waking the parents up, who then take the child to the bathroom, developing a pattern. This is a 66 to 70% success rate if used over 3 to 4 months, but is quite labor intensive for the family. Again, for both daytime and nocturnal enuresis, ensuring a good bowel regimen is in place with proper fiber, water intake, and using Miralax as needed is important. For nocturnal enuresis, another option is to use desmopressin. Desmopressin is a form of ADH, can be used to treat but not cure bedwetting. It causes a decrease in urine production overnight and has a response rate of 50% decrease of wet nights in 60 to 70% of kids. However, this tends to only work if there is no history of daytime incontinence. In general, this should be used nightly for 6 months, then stopped for 2 weeks at a time to see if the child has outgrown their bedwetting. It is important for families to know that relapses are common. Additionally, side effects to watch out for include profound hypernatremia that can even lead to seizures. For this reason, the tab form should only be used and not the nasal inhaled form. Also, parents should be counseled to stop using this product when the child has a condition that could cause fluid or electrolyte shifts. A second option, if desmopressin doesn't work, that can also be used in daytime incontinence, is anticholinergic agents. These help with daytime wetting as well as urgency and frequency symptoms and are often used in a combination for nocturnal enuresis with desmopressin. A third option is imiprimine. This is a tricyclic which affects the release of ADH and also affects arousal overnight. It has been shown to be 60 to 70% successful in the short-term period, but like the other medications, once stopped, most patients relapse. A last option that you can do in daytime enuresis, especially if it is related to a voiding issue, is biofeedback. This trains the patient to relax their external sphincter, allowing them to void completely. Another treatment for patients who have issues with voiding include alpha blockers, such as doxazosine or tamsulosin. These cause relaxation of the sphincter's muscles, allowing the patient to void.